if everybody's here, we're going to start tomorrow morning at 10:30. So a little bit earlier than normal, so that we can make sure we get both lectures out of the way. And then Hugh has a doctor's appointment or something going on. So we want to make sure that we can accommodate her timeline. So we're starting tomorrow morning at 10:30 online. Good to go on that? Yeah, sure. We're good to go.
Yeah.
Great. Okay. So next up, female pelvis. Oops, where am I going here? What am I going? What am I doing? We don't know. Nobody knows. Okay, so you're going to get kind of an overview of the female pelvis, and then you actually have a full class on it next quarter. So the things that we're going to focus on today are going to be pretty easy stuff. So I'm going to teach you about some musculature, some ligaments and things, but you're really going to get them heavy duty next quarter. My concern is more about uterine position, uterine and vaginal and endometrium, kind of the appearance of them and how to know where you are and where this is in the human body. But you're really going to get a lot of this next quarter. Okay, so first things first. What structure is being indicated by the arrow? Describe its location. This is a review for reading. It's an adrenal gland. Where is it located on the kidney?
Superior pole.
Superior. Yep, you got it. And where is the superior pole located in the body?
Near Morrison pouch.
You got it, Morrison pouch, or they call those the pararenal spaces. So there's one by your spleen and there's one by the liver. And then the superior pole is always tipped slightly posterior compared to the inferior tip. Okay. What two structures lie anterior to the right kidney? So here we are in CT. So spine is here. So posterior down here, anterior up here, right kidney, left kidney, not seeing much of the spleen. So what two structures are right here? And nobody knows. Nobody knows. So this
We
is the
forgot
right.
the beginning of question. Please repeat the beginning of the question.
So what two structures lie anterior to the right kidney? So we're looking at a CT.
Mhm.
Here's our right kidney, and here's a structure 1 and a structure 2.
Right kidney.
You mentioned
Right.
Morrison's pouch, right?
Uh-huh.
So where's Morrison's pouch? What are we pouching
Liver.
with?
We see some liquid, some cyst with liquid. No. Or
It's the gallbladder. It's the gallbladder.
Oh, sorry, it's gallbladder.
Gallbladder, and then if that's gallbladder, what is
Liver.
this? Liver.
Liver.
Got it. So liver and gallbladder. Now, anything on CT that is black has a low density. So that's going to be air. So we have air in our bowels here. We're not seeing stomach or spleen very well. We've got left kidney over here, right kidney here. Here's our spine, vertebral process, aorta right in here. There's contrast in it, so it's a little bit bright. IVC, just right lateral to that. Okay. What structures lie left lateral and anterior to the left kidney? So what are we looking at here?
Stomach.
So this is stomach, you got it?
Pancreas.
Pardon me?
Spleen.
Spleen? How about
And
this guy?
Pancreas.
Pancreas. So if this is pancreas, this more what we would consider hypoechoic. What's this more hyperechoic? Goes straight to the aorta.
Artery or vein.
Splenic artery.
Mhm.
Okay, so musculature, vasculature, ligaments, reproductive components, TA and TV directional regions. So we're going to go over a bunch of this today. So we can divide our pelvis up into a kind of a true pelvis or a false pelvis. And the way this is done, I don't know if you guys can see me. The way this is done, it goes from the sacroiliac joint on the lateral aspect down to the pubic symphysis. So everything that is posterior and inferior to here is considered our true pelvis. And then anything that's anterior or superior is considered our false pelvis. So our true pelvis or a minor or lesser pelvis is that what contains the bladder and the sexual organs. Everything else is considered the false pelvis. So let's look at a little bit of an image of that. So this is a coronal. So here we have the pubic symphysis going up to the iliosacral joint. So everything that's within this space, so the inferior or the posterior, is considered our true pelvis. So that has the bladder, the uterus, the rectum, and then everything anterior or superior to that is considered the true pelvis. I'm sorry, false pelvis. Jeepers, you think I know this already. Okay, I am never going to ask you about these muscles, so I'm going to go through these very quickly because I will never ask you about them. But I've divided these up. There's kind of 3 sets of them. I divided them up. Some of them run superior to inferior. So the psoas major, the iliacus. So when we're in transverse, we see these in cross section. They run from superior to inferior. So here they are. So here's our psoas right in here. Our iliacus is more on the lateral aspect. And so when we're in transverse, we're going to see these in cross section. And yes, you will absolutely confuse them for ovaries when you're scanning. And we'll get there next quarter. So terrible image, but here we are in transverse. Here's our urinary bladder right in here. And we're seeing the psoas in cross section on the lateral aspects of our patient. So here we are cross section again. So here, vertebral body, artery, IVC. Here's our psoas in cross section. So they run superior to inferior. Oh man, I went a little crazy here. Iliacus is going to be a little bit more lateral than the psoas. The psoas are going to be towards the spine, towards the medial aspect. Okay, so these ones run medial to lateral. So the piriformis. So basically, it's in the posterior aspect of our patient, and then they run towards the anterior. So there is not just lateral to medial, but like slightly posterior lateral. I'm sorry, posterior medial to anterior lateral. So we're going to see these in length when we are in transverse. So here they are. So anterior lateral, posterior medial. And am I going to ask you about these things? No, Shea will never ask you about these things. Good to know for your registries. Next quarter, you're going to get a whole bunch of this with your OBGYN 1. And here we are again. This is what we would see. So the one prior to this, so in this case, this is our posterior, this is our anterior. So I've switched it around. So this is now our posterior, and this is our anterior as the way we would see it on ultrasound.
Is this still a CT?
Pardon me, I think it's MRI. It looks like MRI to me.
This is MRI. Okay.
But yeah, not ultrasound us, but yeah. Okay, so these ones run anterior to posterior. So we have an internus and an externus of the arbiter. So again, we're not going to see these very well on ultrasound. They're going to be kind of in the background, but you're going to mistake them for ovaries. So when we see these in transverse, we're going to see them in length. But we don't usually see these because we're scanning more of this pelvic region, and these are way low, much more inferior than we usually run. And here they are with stars on them. Again, we don't usually scan this low on our patients. And you'll get a lot of this next quarter. Am I going to ask you this? No, Shea does not give a shit about these. Okay, what I do care about. So our iliacs, we've talked about our iliacs already, and then they're going to bifurcate even more. So they're going to bifurcate into the internal and the external. So one of them is going to be medial. That's going to be your internal, right? It's more internal. Then the external is going to be more lateral. So we care about this when we start talking about male hernias, and we'll get into that next week when we talk about the male pelvis. But we don't really care about these so much on the female pelvis. But these are going to cross that sacroiliac joint on the anterior aspect. So remember where our ureters like to get compressed with pregnancy. So the pregnancy is pressing on these ureters. Our patients get hydronephrosis. And so we're going to have maybe fetuses that are up against these things, but we don't really care about them when scanning other than to evaluate our iliacs themselves, like you guys have done already. So let's talk about our internal. So this is going to branch again. So we have our iliacs branching into internal and external. So external, internal, and they're going to run across that psoas muscle. And then we have the inferior epigastric and deep circumflex. The inferior epigastric we really care about with male pelvis, but we don't care about the deep circumflex. So here we are. So here's our commons. So you guys have scanned these already. So you did proximal aorta, mid aorta, distal aorta, right and left iliac. And then these are going to bifurcate into the internal and the external. So internal are going to be medial, external are going to be lateral. And some of you probably did this by accident. You went so far down on your patients, but yes. Here's another graphic. So we're at the distal aorta right here, bifurcating into our iliacs. So we have our external and our internal. Okay, so now this is coming up from the legs. So we went artery down, splitting into legs. Now we're going veins up, going into the IVC. So we have an external and an internal as well, and then they're going to confluence together to become our iliacs. So this is the reverse of our arteries. This is the venous side. So here we go. So we have our internal and our external confluencing together to form our common iliacs. And the common iliacs are what you guys have kind of maybe seen by accident when you were doing your AAA exams. Okay, any questions so far? Okay, so when we look at our female pelvis, we're going to put our transducer in sag or transverse on the female pelvis. And then we look at the bottom of our image, we're going to see the rectum. It's going to be posterior to the uterus. And there's a potential space for fluid collection there, what we call the pouch of Douglas, the posterior cul-de-sac. And we annotate it either PCDS or POD, pouch of Douglas, posterior cul-de-sac. It's also called the recto-uterine pouch. So rectum, uterus, recto-uterine pouch. Remember Jim Morrison? Everybody loves the Doors. So James Douglas Morrison. So this is the pouch of Douglas. We've already looked at Morrison's pouch. There is no James pouch. I apologize for that. But this is the area between the rectum itself and the posterior aspect of the uterus. Then we have the uterus. So the uterus is going to live in there. So we have a potential space between the bladder and the uterus called the vesico-uterine. Remember, vesico means bladder. So vesico-uterine. So between the uterus and the bladder itself, the vesico-uterine sac, which is also called the anterior cul-de-sac. So we have one behind the uterus, posterior cul-de-sac. We have one above the uterus, anterior to the uterus, which is the anterior cul-de-sac. Then we have—
Sorry to interrupt. Can someone who's not muted, please mute yourself? Because I hear a lot of background talking. Thank you.
We good to go? Okay.
Yep.
I don't know who that was. I have no idea. Okay. Okay, where are we? Yes, from current slide. Okay. Okay, so we started the most posterior. We had the rectum. Then we had a potential space, the posterior cul-de-sac between the rectum and the uterus. Then we moved more anteriorly, so we have the uterus, and then we have a potential space between the bladder and the uterus called the anterior cul-de-sac. And then we also have another potential space between the bladder and the abdominal wall. And that's called the space of rhesus. And we don't often get fluid there, but it's one place that we're going to notice when we're scanning. It's just going to be in your images. So there may be some potential for fluid there, but less likely. Most of the time your fluid's going to accumulate in your posterior cul-de-sac. And then the most anterior and inferior is going to be the pubic bone. And it's this very dark shadowing thing. When we get into scanning kidneys next week, we'll look at this. This is kind of how you prove that you're at the bladder region, even though you don't see a bladder. But it's kind of an area that we use to kind of prove location. So here we go. So this is how a patient would be like maybe sitting on a chair, and then I rotated it. So this is how we're going to see them on ultrasound. So we're going to see the rectum in the most posterior aspect. Then we have this potential area for fluid, the posterior cul-de-sac. Then we have our uterus, vaginal canal going down. The lining of the uterus is called the endometrium. That's the part that sheds every month. So myometrium, endometrium. We'll talk about that here in a second. Then we have this other potential space between the uterus and the bladder itself. So that's going to be our anterior cul-de-sac. And then we have a third potential space that we don't often see fluid in, and it's that space of rhesus, and it goes between the bladder and the pubic symphysis. Most commonly, what we're going to see is this pubic symphysis is a big echogenic shadowing structure, and that's how we prove when we look at our patients' bladders, whether they're, they voided all the way. So we kind of prove our location by showing that pubic symphysis, and we'll get into that next week. Okay, so here we go. So we're sagittal on our patient. So superficial fat and fascia here. Here's our urinary bladder, this big anechoic area. We have vaginal canal coming down here with this lighter arrow. So vaginal canal opening up into cervical land. So the cervix always has kind of this bulbous kind of structure to it. And then we're going to go into the uterus itself. And the uterus has parts to it, believe it or not. So we have, oh, where's my mousey? So we have cervix down here. We have lower uterine segment. We have what we call body or cornua. Those are used interchangeably, although truly the cornua is where the fallopian tubes exit off of the uterus, but we use these interchangeably, and I've lost my mouse, interchangeably out in the real world. So body cornua, and the fundus is the most superior portion of this. This echogenic line that we're seeing is the endometrium, and the vaginal canal and the endometrium will both have this kind of echogenicity to it. And it's not that it's very bright, it's a specular reflector. So what you're seeing is the two layers of the mucosa, kind of like, it's like a shirt sleeve that's closed, it's collapsed. And so we're seeing two sides of the mucosa opposing each other, and it's very flat. And so our beam will bounce it back as very bright, although it's not like calcified or anything like that. And we can see that not necessarily in this image, but we can see that in the vaginal canal, and we'll see it very well in the cornua body of the uterus. And then the endometrial thickness will change depending on our patient's cycle. So if they're getting ready to menstruate, this is going to be very thick. If they've just menstruated, which is what this particular patient looks like, it's going to be very thin. And then as our patient progresses towards menstruation, we get this basal layer that gets hypoechoic. And you'll learn about that next quarter. It's the spiral arteries coming in there to perfuse the endometrium. So basically, it's like setting up shop to have a baby. And then we don't have a baby, so we shed all of that out every month. But that's what you're seeing the brightness of, is just the opposition of those mucosal layers. So it's not that it's echogenic because it's calcified or very dense. It's echogenic because it's a specular reflector. Okay, now we're in transverse. So we've switched to transverse. So here's our uterus and transverse, seeing a little bit of that endometrium right in the center portion here. We've got a left ovary here with some dominant follicles in it, very normal looking. And then we have a right ovary over here with a hemorrhagic cyst in it. So you can see it's got a big cystic space, has kind of uneven spider webbing to it. If you roll your patient, these will not change directions. They will not change the lie of the fluid. So it's a hemorrhagic cyst. And hemorrhagic cysts love to occur in the ovaries. So right ovary with a hemorrhagic cyst, uterus right in here. Posterior to the uterus is going to be, okay, let's get out of here. My menu is pooping its pants. Down here is going to be our rectum. And our potential space, the posterior cul-de-sac, is going to be posterior to the uterus. Our anterior cul-de-sac or vesicouterine would be between the bladder and the uterus itself. And then we get on the left ovary and we're seeing dominant follicles. Interesting thing to note. You'll learn about this next quarter too. So we have dominant follicles, women have dominant follicles every month that develop. And they get large, and then eventually that cystic space is going to ovulate, and a little egg is going to come out, get picked up by the fibra of the fallopian tubes, and perhaps go back into the uterus. Sometimes these developmentally don't stop growing, and they get larger and larger and larger. So if you have a dominant follicle that's over, depending on where you work, 2.5 or 3 centimeters, they consider that an ovarian cyst. But it's what it is just an overgrown dominant follicle. So we can have, as we do on the right here, we can have a hemorrhagic ovarian cyst, or you can have a simple ovarian cyst, but all they are dominant follicles that just never ovulated. They just got bigger and bigger and bigger. And so if you take like my world into consideration, I'm a twin, and my mom only had one ovary. She had an ovary removed for whatever reason. I don't know. But my mom had one ovary that had 2 dominant follicles on it. Both of those follicles ovulated and became me and my brother. So that's kind of the way it works. Sometimes they don't ovulate and they just get larger and larger, and then they're considered an ovarian cyst. And so we use the word cyst kind of loosely with ovarian stuff, because it's not like a cyst in the kidney that will persist, or a cyst in the liver that will persist. These will eventually rupture, and they're very painful. The patients I have with these are very painful patients, but eventually these will rupture. And yeah, it's just painful. It's just really painful. So the ovum that's in them is at that point, what's the word I'm looking for? It's not able to be fertilized. So they get to that size. So we see a lot of those. This is going to be a very common exam for you guys to evaluate. And additionally, when they get cysts that are of this size, 2.5 or 3 centimeters, depending on where you work, when they get that size, the ovary contorts itself. We talked about testicular torsion a little bit, but ovaries can do this as well. And so it'll actually twist on its pedicle and twist its blood supply so that there's no blood profusing and no blood exiting the ovary. And so that's one thing we're going to have to look for. You'll learn this next quarter, but we'll have to look for ovarian torsion due to cysts or mass in the ovary. So this right ovary is at risk for torsion. Any questions on my giant, ridiculous spiel on ovarian cysts? Okay. So next up, we're in transverse again, and we're starting to see a little bit of free fluid in the posterior cul-de-sac. So here anteriorly is our urinary bladder. Here's our uterus right here. We're not seeing very much endometrium. And this is what we call the broad ligament. We'll talk about him in a second. And then posterior to our uterus, so between the rectum and the uterus and our posterior cul-de-sac, we have some free fluid. So free fluid is a little bit different than ascites. Ascites we think of as being more in the abdomen and being caused by like congenital heart failure or liver failure or kidney failure or some sort of abdominal structure failing or venous stasis, venous overload in the abdomen. And with free fluid, it's more typically in the pelvis, and it's as a result of, so maybe I had one of those ovarian cysts and it finally ruptured, and so its fluid is loose in the pelvis. Or my patient might have an ectopic pregnancy. Or sometimes we see what we call a little bit of functional fluid, which is a normal amount. It just helps things kind of slide around. So we might see just a trace of functional fluid around there. But free fluid, similar to ascites, but they're different. The causation of them is different. And so if I see a pelvic patient with this, I call it free fluid. If I were to see this as ascites up in the abdomen, I would assume that was because of organ failure, heart failure, something like that. And so I would call it ascites. So it just depends on the reason the fluid is occurring is what you're going to call it. So ovarian, uterus, testicular, pelvic fluid, free fluid. Fluid in the abdomen due to organ failure, congestive heart failure, congenital heart failure is going to be ascites. So it's a little bit tricky on that one, but this is going to be free fluid.
Shea, I just have a question. So
Sure.
if it was from like liver failure and ascites, you could still see it down here in the pelvis.
Correct. Yes.
Yeah.
But my patient demographics would kind of lead me one way or the other.
Yeah. Okay. Just
So if like, oh, she has a positive HCG, positive pregnancy test, but we can't find a fetus in her uterus, but she's got all this fluid, I'm thinking free fluid. Or she had an ovarian cyst that ruptured, free fluid. But if this patient is history of ethanol use, history of congenital heart failure, history of kidney failure, then I'm going to think ascites.
that makes sense. Thank you.
Okay, so here's a little bit more. So we're in sagittal now. We're sagittal on our patient. So we have an anechoic urinary bladder here. This is our kind of skin line, superficial fat and fascia, vaginal canal coming in. Remember, it's bright because of the opposition of the mucosal lining. So it looks bright, not calcified, just a specular reflector. Here we're coming into the uterus itself, and posterior to the uterus, we have this little tiny crescent of anechoic fluid. So we got free fluid in the posterior cul-de-sac. And then down posterior to that is going to be our rectum. Terrible image. Bear with me. So this is a transvaginal image. So I'm not seeing vaginal canal. When we do transvaginals, our probe goes against the cervix. So this is actually the posterior aspect of the cervix right in here. And then we get into the lower uterine segment, cornua or body, depending on who you're talking to, and then fundus up here. Here we're seeing the endometrium. That's that opposition of the mucosa. So we have free fluid in the posterior cul-de-sac. And we also have free fluid in the anterior cul-de-sac. And we're not seeing bladder very well because we're transvaginal. Okay, questions on that? Well, that's a big fat no. Okay, so
I have a quick question.
sure.
Why is the free fluid, like, why does it cause the patient so much pain?
So the free fluid itself doesn't cause pain. It's the reason we have the free fluid that causes pain. So like an ectopic pregnancy or a ruptured ovarian cyst. So that will result in free fluid. But the pain they're experiencing, so like when I talked about those ruptured ovarian cysts, those are my most painful pain. Well, there's a couple other types, kidney stones and torsion. But those are really painful patients because that cyst is rupturing. So once the cyst ruptures, they're pain-free. They have free fluid, but they're pain-free at that point. If they have an ectopic pregnancy, they're going to have pain because those are never painless. But the free fluid is accumulating because of that ectopic pregnancy, the inflammatory response associated with having an ectopic pregnancy. Does that make sense?
Yes, thank you.
Good to go?
Yep, good to go.
Okay. So pelvic ligaments. Oh, geez. Am I going to ask you about these? No, not at all. Nope, Shea doesn't care. And in the real world, we kind of refer to all of these as the broad ligament. So when we're looking at this uterus, let's go back one step. So when we're looking at the uterus itself, we see this ligament coming off the lateral aspects of it. And that's a very good place to look for our ovaries. And as a general term, we call that the broad ligament. However, the broad ligament is more like a sheet that runs from the lateral aspects of the uterus into the adnexa. Remember, adnexa is the word for anything outside of the uterus laterally. So it runs from the lateral uterus to the pelvic walls, and it's a big sheet. We don't appreciate it that way when scanning. Instead, we see more of like a hypoechoic tissue extending from the fundus of the uterus out laterally. And that's actually the suspensory ligament. So broad ligament, a big sheet, suspensory ligament, kind of more this more visible thing, but we call it the broad ligament in the real world. So they're used interchangeably. Then we have one that's going to do the fundus of the uterus to the lateral pelvic wall. It's called the round ligament. Don't confuse this with the other round ligament that you guys learned with the liver, right? You remember that one? So that one runs from the left portal vein to the umbilicus. That's also a round ligament, different round ligament. Why we not name them different things? Who knows? I don't know. I didn't make this up. But anyway, so the round ligament, and then we have the ovarian. So the ovarian is from the cornua, so where that uterus, where the fallopian tubes attach to that uterus, and then they go to the ovary itself. But as a general rule, we just call this the broad ligament. I'm not going to ask you anything about this. Next quarter, you're going to get more about this, and you probably will get asked about this, but not something I'm ever going to ask you about. But when scanning, when we talk uteruses next quarter, I'll say, did you follow the broad ligament to find your ovary? And just know that that means that hypoechoic area that comes off the cornua or the body of the uterus. Okay, so here we go. So this whole sheet is going to be our broad ligament, the whole thing. When we have a suspensory ligament, that's just basically architecture. It's just holding things up. Ovarian ligament, So he's going to be the one that holds the ovary close to the uterus. And as our patients have had what we call multiparous, so they've had children before. So parity is how many children you've had. So multiparous, the more children you have. That's going to stretch this out a lot. So ovaries get harder to find on patients who have had children because the ligaments stretch out. They can kind of, ovaries, in general, ovaries have lives of their own. They can hide behind bowel. They kind of travel around. I'll be looking at one and I'm frozen and I do my measurements on it and I unfreeze and then it's just disappeared somewhere. Where did it go? Where did it go? Where'd the ovary go? Who knows? So ovaries have little minds of their own. But as a general rule, the more children that a patient has, the more difficult it is to locate ovaries because all of these ligaments get stretched out. And then, of course, the round ligament is going to be this more significant, just tucking the fundus of the uterus up in the body. And there's a thing, okay, well, I don't know how crazy I want to get with this one. We'll talk about that later. Let's do that one later. It's gross. We'll talk about it later. Okay, so here we are. We have a significant amount of free fluid, and this is called the TIE fighter sign. So basically, the only thing that's holding this uterus up is the ovarian ligaments, and there's a urinary bladder up here, and then the posterior is free fluid, but it's called the TIE fighter sign. Are you guys familiar with Star Wars? Yes, we love Star Wars. Yes. So they fly around these like spaceships called TIE fighters. And this is what they look like, except this is a uterus, but they have like little tiny wings on them. So this is the TIE fighter sign. And I don't know who spells uterus this way. Not me. Was not me. Okay, so now we're seeing a mass. So here's our uterus in transverse. And we're actually seeing an ectopic pregnancy mass within the the left adnexa. So here we're seeing our suspensory ligaments, our ovarian ligaments holding this uterus up. We've got urinary bladder up here, free fluid down here, and we're seeing an ectopic pregnancy in this left side. Okay. Questions? Okay, well, let's talk about girl parts. So we have external genitalia. We have what's called the adnexa. So that's within the body. It's the area just lateral of the uterus to the side of the pelvis. So when we're scanning this uterus, if I see any components of uterus and sagittal, I'm not in the adnexa. I have to be all the way out of the uterus in order to see the adnexa. Then we have the vaginal canal. So there's a urethra, what we call vaginal fornix. And we'll talk about that next quarter when we scan. When we look at those along the cervix, that becomes a landmark for proving that we are at the cervical portion of the uterus versus being lower uterine segment, body, cornua, fundus, that sort of thing. Cervix, of course, uterus, fallopian tubes, 2 of them, and then ovaries times 2. You can have more ovaries. You don't usually get born with less. Usually you have multi-ovaries if anything weird is going to happen. So external genitalia. So there's labia majora, labia minora. So one of them is going to be more lateral. So that's the majora. And the ones that are more medial are going to be smaller. And those are the ones that actually encircle the vaginal canal. So there's a clitoris there, and that's going to be anterior to the vaginal opening. And then the urethral opening is actually anterior on the aspect of the vaginal opening. So if we're looking from anterior to posterior, it's going to go clitoris and then vaginal, then urethra and then vaginal opening. Then we have the perineum, which is the area between the vagina and the anus. And then the anus, of course, is going to be most posterior. I'm sure I have some great pictures of this. So starting at the most anterior portion is the clitoris. Then we have the urethra on that anterior portion of the vaginal opening. So vagina is here. Labia minora are going to be more medial. Labia majora are going to be more lateral. And for some reason at my work, this guy named Matt, who works the night shift, gets perineal abscesses like nobody's, not that he has them, he has to scan them, like nobody's business. He is like known for the amount of perineal abscesses that he has had to scan. I'm like probably 2 a month. And I've probably done 5 in my entire life. So poor dude. Okay, so adnexa. So this is internal. So this is the area between the uterus and the lateral aspect of the pelvis. So the medial portion is going to be the size of the uterus, so fallopian tubes, ovaries, uterine vessels. The lateral is going to be where the common iliac arteries and veins are. So as we scan out, we're going to see more vasculature with the iliacs. So here we are again, we're in transverse. Here's our urinary bladder. Here's our uterus. And so we're able to see in cross section, because we're in transverse, those iliac arteries and veins on the lateral aspects of our uterus. So this portion is considered the adnexa, where there is no uterus. Okay, vaginas. Let's talk vaginas. So posterior to pubic symphysis, we're going to see this posterior to the bladder, obviously to the urethra as well. And our urethral opening is going to be anterior to the actual opening of the vaginal canal. And then there's a thin tissue called the hymen, and we'll talk about some pathologies associated with this. One of them is obviously imperforate hymen. So normally the hymen is a thin tissue and it's shaped like a donut where it has a hole in the center. And so like menstrual products can come out, patients can use tampons, things like that. But there's a condition called an imperforate hymen where there's no hole in the donut. And what will happen with those patients is they'll menstruate and those menstrual products never leave the vaginal canal. And so they'll get backed up into the vagina, into the uterus, and it's called imperforate hymen. We'll talk about it next quarter with pathology. But basically those menstrual products never leave. And so those patients never know that they're menstruating. They might feel discomfort, and eventually it'll get so uncomfortable that they'll come into us, but it's called imperforate hymen because their hymen doesn't have the hole in the center to allow blood products to exit. Okay, so vagina. So smooth muscle, some skeletal muscle in the inferior portion. Then we have, so the vagina encircles the cervix at the very lower portion, the most inferior portion of the cervix, and that's called the external cervical os. And we can see that on ultrasound. We'll look at it next quarter when we start doing female pelvis exams, but we see that as kind of a shadowing. It's going to be kind of a shadowing of the vaginal fornices. So it's like pockets around the cervix. So our vagina encircles the cervix and there's pockets around it, pockets of tissue. So we see anterior, superior, left lateral, right lateral. And we can see this in TA images, but when we do transvaginal images, our probe is actually in the vaginal canal. So we don't appreciate the vaginal fornices when we're transvaginal. We only appreciate it when we're doing transabdominal. So here we are, sagittal on our patient. Here's our urinary bladder, vaginal canal down in here, coming around to that cervix, that posterior aspect of the cervix, and then into the lower uterine segment, body cornua and fundus of the uterus. Let's see if we have a better one. That's the same one. We don't have a good one. We don't have a good one. Okay, so the cervix is the inferior extension of the uterus itself. So it's made up of uterine tissue, but it gets very dense and thick. And this is the part like when, babies are born, the cervix dilates, yada, yada. You guys have all heard this, but it's a kind of a thicker, more dense portion of the uterus. So we speak about it having osses. So the internal os is the portion that goes from the cervix to the uterus. The external os is a portion that goes from the lower portion of this cervix, the inferior portion of the cervix, to the vaginal canal. When we evaluate this in obstetrics, we're going to do a cervical length, but we don't do dilation. They can say, oh, there's 4 centimeters dilated. Like, okay, fine. Its length is 2 centimeters. So we do a cervical length. We don't do a cervical dilation. And so we're going to find this out next quarter when we do female pelvises. And when we're in transverse, we're going to prove that we're in the cervix, because when we come down to that external os where the vaginal canal is encircling that, it's going to have some edge artifact and it's going to shadow. And so that's how we prove we're in the cervix, is by showing that shadowing. So we'll talk about that next quarter when we actually scan it. So here is a transabdominal cervix with a pregnancy. So here's our urinary bladder, vaginal canal down in here. So cervix right in here, and we have a baby in here, a little fetus growing around, some amniotic fluid. And in this case, here's our cervical canal. So we do cervical length. We don't do dilation. But there's our cervical length. Here we are again, very prepped patient, kind of compressing. And we'll talk about this next quarter, but if I have a patient that has this full of a bladder and I'm trying to do a cervical evaluation on them, I'm actually going to have them use the restroom, or I'm going to go transvaginal, because the pressure of the urinary bladder can actually compress down and make our cervix look longer than it should be. And we want to make sure we're getting an accurate cervical length. And so in this case, I would have this patient void or do a transvaginal. But here we are. So urinary bladder, vaginal canal down to here. Here's our cervix. So we have our external os here, internal os. Looks like it's creeping all the way up here, but again, that's just because of the pressure from the bladder. So we've got our cervical canal right here that we'll measure in obstetric patients. And this is a very common measurement that you guys will do. And then we have a little baby brain, half a head up here, little amniotic fluid. Okay, so here we are transvaginally. So we've had our patient use the restroom, and we've actually put the probe into their vaginal canal. So we don't see vagina because we're in the vagina. So instead, we're starting at the posterior aspect of the cervix. What is going on here? Anybody?
Free fluid.
Trace free fluid in the posterior cul-de-sac. You got it. And there's a small amount that we expect to be there just so things can slide around. So this is a very normal amount of free fluid, and I've lost my mouse. But in this case, so we're in the vaginal canal. Here's cervical canal coming around. And this one has a little bit of complexity to it. It probably has some hemorrhage associated with it. So this patient might be bleeding. And then we're not seeing more towards the internal os, but there's probably a baby up here somewhere. Here we are again. So in this case, we're transvaginal again. So we're in the vaginal canal. So we're not seeing vagina. Here's the posterior aspect of our cervix. A little bit of free fluid. Again, we expect that. It's like our functional amount of fluid, just so things slide around. And this cervix, what is going on with this cervix? What's happening here?
There's fluid.
Fluid. Yep, we've got fluid in the cervical canal. So that indicates with an obstetric patient, that indicates that maybe our what we have called premature rupture of membranes, PROM. Not like prom that we went to in high school, different prom. But we'll talk about this next quarter. But basically, there should be a membrane here that closes off that internal os. And in this case, we've got a little bit of clot and hemorrhage. And then we've got some free fluid within that cervical canal. So not good, not good. Okay. So the uterus. Uterus is pear-shaped. So it has, the fundus can kind of rotate towards the posterior, towards the anterior. And then as I have my patients, so my patients have a full bladder and their uterus is kind of laid out flat. And as I have them void and then come back in for the transvaginal, that uterus will actually take a few minutes to kind of curl back up into its position. And there are 3 layers to the uterus. So the peritoneum, so it's the outer layer. That's, if we look here, that's going to be this echogenic kind of specular reflector on the outside of the uterus. So that's the peritoneal layer. The myometrium. So if we go back again, the myometrium is going to be the muscular layer. And then let's go endometrium. So the endometrium is that portion that sheds every month. So those are kind of our 3 layers of the uterus. When we talk about referencing pathology, we always reference pathology to the endometrium because the uterus is so variable in location that we want to make sure that we're doing it. In fact, let me do this right now. Let's do the whiteboard. Okay, so when we have a uterus, so we saw this kind of earlier. Here's our endometrium here. Boop, 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 boop. Okay, that was terrible. Let me undo that one. So whenever we reference pathology, we're going to reference our pathology in relation to the endometrium. Let me get a different color. Can I do that? So this is going to be our anterior, posterior, superior, inferior. So inferior is always going to be towards the cervix. Superior is always going to be towards the fundus. Anterior is always going to be above the endometrium. Posterior is going to be below. So sometimes we have uteruses that do crazy things, and they're like retroflexed. So I might have a uterus like this. Let me get my color out again. So if I have a pathology here, that's the same as having a pathology here. So this is going to be the anterior portion, say mid-body, and this is going to be the anterior portion. So we always reference the endometrium. So let's get another goofy uterus. Sometimes they're super retro. And so we have to know, where's my color? So while this looks like it's in the posterior, this is actually the anterior. Posterior is here, superior is at the fundus, inferior is towards the cervix. So our uteruses can have variable lies. So we always reference the endometrium when talking about pathology. Does that make sense? Yes, no, maybe not, no, maybe, no, no.
Yes.
Yes.
So the fundus is always going to be towards the superior. The cervix vaginal canal is always going to be towards the inferior, regardless of how our uterus is oriented. Anterior is always going to be above the endometrium. In this case, above the endometrium. And our posterior is going to be below the endometrium. So we kind of reference it as if it looked like this. This is the worst uterus ever. But that's how we reference it. So we always reference it in relation to the endometrium. Does that make sense? Don't worry, you'll forget about this later. It's okay. More on this next quarter. You have a ton of this next quarter. Okay. Oops. Okay. And that endometrium is going to change in appearance depending on when our patient is menstruating. So sometimes it looks very thick, sometimes it looks very thin. And when we get into next quarter, we're going to start asking our patients, when was your last menstrual period? So if I have a patient who was like, oh, I just finished my period a day ago, and they have a really thick endometrium, I know there's a problem. Or if they're like, oh, I haven't menstruated for months, and they have a really thin endometrium, I'm like, okay, we've got a problem. And so we can use that endometrial thickness to kind of gauge where our patients should be at and what we're seeing in relation to what they should be looking like.
Shea, I have a question.
Sure.
So you're saying if they like haven't menstruated in months and they have a thin endometrium, there could be a problem. What if they're on like, they have like an IUD or something where they're not supposed to be menstruating?
Got it. You got it. So progesterone only birth controls, they have a very thin endometrium. They can still have bleeding. They call it breakthrough bleeding. They can still have bleeding with that, but we will see a very, very thin endometrium.
Okay,
So
and
yes,
then that
birth
would be
control
normal.
becomes an issue.
But it would be normal based on like what kind of birth control they're on?
Correct, because like a triphasic or a biphasic, they're going to have that thickening of the endometrium. But if they are on a progesterone only birth control, they should never have a thick endometrium.
Okay.
Yeah,
Got it.
so it just depends and whether they have an IUD or they're using like Depo-Provera or the Norplant or something like that will depend too. Like you'll see IUDs in there as well.
Yeah.
And usually IUDs look like echogenic shadowing things. So we'll have to measure the endometrial thickness laterally to that.
Okay.
Yeah, so we'll get into that next quarter. This is
Okay.
just your intro to the uterus.
Thank you.
Just your intro. Okay, so fundus is the most superior portion of the uterus. Then we get on, it's called the cornea or the corpus. That's where the fallopian tubes extend off. And some people call it body. I usually call it body. You're going to run into other instructors who don't call it that. It's just the way the world works. Some people call it one thing, some people don't. Then as we transition more inferiorly towards the cervix, we get into the lower uterine segment where we have that very narrow aspect of the uterus. And then we get into the cervix. So internal os being towards the uterus, external os being towards the vaginal canal. And then we talked about that imperforate hymen earlier where blood product is not allowed to escape. And we can also have cervical stenosis. So my patient had a LEEP procedure, they had some sort of biopsy done on their cervix or some sort of scarring, or they have an infection within their cervix and their cervix closes up. So I can actually have the same thing happen, not due to an imperforate hymen, but because those blood products aren't allowed to leave their cervix. And so we can all have the cervical stenosis, so they can have a buildup of menstrual product within their uterus simply because their uterus is stenosed, or cervix, I should say, is stenosed. So yes, interesting stuff. Can't you wait? Yes, yes, yes. So here's a transabdominal uterus, and there's a little ovary back here in the posterior aspect. We're not seeing much of vaginal canal in this neighborhood. Normally we'd see this a little bit more clear. Here is our cervix region, moving up to lower uterine segment, moving up to cornua body, and finally at the most superior aspect, fundus. So you'll see this endometrium looks much thicker than this one. So see, this guy's very thin, maybe post-menstrual, maybe on progesterone, something where we don't have a very thick endometrium. And then you can see this one is much thicker. And we measure these out in the real world. We're going to measure the AP in these. We'll get into that next quarter.
Shea,
Yes.
what is that in the posterior lower?
It's an ovary,
That is? Okay.
a brovary for you. Yeah, it's an ovary. Okay, now we're in transverse. So we've gone from sagittal to transverse. We're seeing a little bit of free fluid kind of floating around the posterior cul-de-sac. So here's the myometrium, this muscular layer, and then we're seeing the endometrium. Again, it's bright because of the opposition of the mucosa, not because it's calcified. But you can see we have a little bit of thickness on this left side compared to the right side. So we have some dissymmetry, some asymmetry within the endometrium. We'll get into that next quarter. Don't worry about it now.
What is the circle structure posteriorly? Is it
This?
intestine? Yeah. Or what?
Rectum.
Rectum. Okay, got it. Thank you.
Rectum, damn near killed him, right? Okay. Okay, so here we are transvaginally. So we're in the vaginal canal, not really seeing that posterior cervix very much. So lower uterine segment here, into the body cornua here, and then fundus finally at the very, very top. And here's our endometrial stripe right in here. What else are we seeing?
Free liquid.
Free fluid. Yep, you got it.
Fluid.
Okay, so a normal uterus, like I showed you guys earlier, is what we call anteverted. So the fundus points towards the anterior portion of our patient. And it can flex one of two ways. It can flex at the body itself, or it can flex at the cervix itself. So the way I remember this, flexion is in the body. Version sounds like cervix, version with a V. So version is when it flexes at the cervix. And then flexion is just at the body itself. And we can also have what we call dextro or levo, where it flexes to the right and left. But you'll get that next quarter. I will not ask you about this at all this quarter. But here's some different types. So this is what we normally see. So the fundal portion is pointed towards the anterior. And then we get retroflexion. So flexion's at the body. So the cervix is straight, and then the body flexes towards the retroperitoneum, flexes posteriorly. This is a type of retroversion. This is the worst uterus you're ever going to scan in your life because you can never get a true transverse on it, despite what you want. And then this is the thing I was going to talk about earlier that was super gross that I'm not going to talk about, but it's called a prolapsed uterus, when these things start to fall out. And I've got an excellent cow story related to this. But here we can see the body of the uterus pointed towards the posterior. This is going to be our more normal position, where our fundus is pointed towards the anterior. So here we are transabdominally with a retroflexed. So the cervix is straight. And then we have the body of the uterus is actually dipping down, dipping posteriorly. So here's our endometrium. Here's our fundus. So these ones can be really hard to scan transvaginally. We'll get into that next quarter. These can be a little bit difficult. Here we are transvaginally with a retroflexed. So prior to this, we were seeing our posterior cervix on the right side of our screen. against the notch. And in this case, we're seeing the cervix where our notch is. And so in this case, we're backwards. So this would be the anterior portion of our uterus. And this would be the posterior portion of our uterus. Remember, we're going to use that endometrium to determine exactly where things are at. So anterior towards the bottom of our screen, posterior towards the top of our screen. So a little bit reversed from what we've seen before. Okay, fallopian tubes. Any questions so far?
We don't see them if no pathology.
Correct. We don't want to see them. If we see them, something's gone haywire. So there's three major parts to them. So there's the isthmus, which is like right where it attaches to the uterus. The ampulla, which is like basically the tube itself where fertilization occurs. And then the infundibulum. So this is the one that has a little fibra on it that communicate with the ovaries. They're like little fingers that try to like suck up the little eggs that are ovulating. Tickle. I guess I have tickle on my, okay, I don't know why I put tickle, but okay, tickle. They tickle the ejected eggs. So here we go. So here's the portion that connects to the uterus. Then we have just the kind of the tube itself. And then we have the fibra at the infundibular, and then there should be an ovary right next door to this. So here we have what's called hydrosalpinx. Again, a pathology for next quarter, but our fallopian tube is dilated with fluid in it. So we're seeing uterus is going to be over here on this portion of the image. And then we've got this fluid-filled tube, and near this would be an ovary. But hydro, fluid, salpinx, fallopian tube. So fluid, fallopian tube, hydro, salpinx.
Did you say about fallopian tubes that we don't see them on ultrasound?
Normally we don't. No, we shouldn't. So it's kind of like ureters. If we see them because they're fluid filled or pus filled or something, that's bad. Normally we don't see them at all.
Shea, is
Yeah.
there a procedure with saline where we visualize the fallopian tubes?
We don't, but yes, there is.
Oh, okay.
So,
Is-
so they can do multiple procedures. So we do the one that actually puts saline into the uterus itself.
Yeah.
But it doesn't extend into the fallopian tubes. They typically do that under fluoroscopy with a
Yeah, I've seen that.
Yeah,
Okay.
with a dye.
Okay.
And so we don't typically do it.
Why don't we do it?
Great question. I don't know.
More saline.
We-
I don't know.
We did it
Yeah,
a lot for fertility. It
Yes.
was just to make sure like your tubes are open or there's nothing really
there's
wrong
any
with that.
scarring. Yeah, yeah. But,
Yeah.
I don't know why we don't. Let's Google that. Let's look it up right now. Let's Google it. Let's Google it. Why doesn't ultrasound do salpinx imaging? Salpinx imaging. South pink imaging. Okay, that's not quite. Okay. Okay, so this is what I'm seeing. Comparison between CT and ultrasound. CT sensitivity is higher. Predictive values were calculated higher.
Okay.
So yeah, I think it's just better than us.
Uh-uh.
Fluoroscopy, MRI. Yeah, that's fine. I'm fine with not doing it. I'm fine with that.
Okay. Sorry.
One more thing on my list, right?
Yeah.
Okay, so here we are again, hydrosalpinx. So this is fluid within the fallopian tube. We also get what's called pyosalpinx, where you can get pus in the fallopian tubes. And we'll talk about that next quarter. It's kind of a part of a, you get a uterine infection. Okay, you guys remember seeing those STD posters when you were in middle school or high school? And they had like the big sausage looking fallopian tubes. and it's part of what we call PID, pelvic inflammatory disease. So oftentimes pyosalpinx is more associated with things like uterine infections, so chlamydia, gonorrhea, a terrible urinary tract infection gone bad, but this is just hydrosalpinx, so it's just fluid. But we'll get into pyosalpinx next quarter. Okay, ovaries. Oh, everybody knows about the ovaries. So ovaries kind of have two layers to them. So we have the cortex, and when you look at an ovary, oftentimes they look like chocolate chip cookies, and on the periphery of them is where their little anechoic cystic dominant or not so dominant, immature follicles are. And then there's a cortical layer that kind of surrounds that. And then the medulla is the very center of that. And that's more like where the vessels come in, lymphatics, nerves. When we look at color Doppler on our ovaries, that's going to be where we have more color Doppler to pick up versus in the periphery. Okay, we'll go through this next quarter, but hormones are important. Yes. Estrogen, progesterone. Yes, yes, yes. So these follicular development, do I have one of these in here? No, I don't. So this is a prime example of what we call PCOS, polycystic ovarian syndrome. And that's misleading because we think of cysts as being large, but with polycystic, they never reach maturity. So you get all of these immature follicles in the periphery of your ovary. So here we have, out here is the periphery, and then internally to this is the medulla. So this is kind of the meat and potatoes of the ovary. And so that's going to have the vasculature, lymphatics, nerves, etc. And then our dominant follicles, although these will never go dominant because they're PCOS patient, but our follicles develop in the periphery of the ovaries. Okay, I'm not even going through this. Let's not even worry about that. We'll do that in class. That's it. That's all I got for you guys. Are you all asleep? Are you all dreading your lives?
No,
What do we
no.
actually need to know? Because I feel like a lot of stuff was kind of skipped through, so it's
So
hard.
the things that I'm going to ask you about is where is this pathology on the uterus? If I have a retroflexed uterus or an antiflexed uterus, antiverted, retroverted, where is the pathology? It's in the anterior lower uterine segment. Be able to draw that.
But that's, I mean, that's just pathology. I mean, yeah, you need to know how it lays, I guess.
Yes, yes. And so I'll ask you to draw a picture of a retroflexed uterus transabdominally or transvaginally, and where is its pathology located?
So nothing about other structures.
No,
like-
I don't give a shit about any of that. No, you're going to get that. You have a whole quarter of this next quarter.
Okay.
So I'm not too crazy about the ligaments, the muscles. I'm not too crazy about any of that. It's more the location of the uterus, the variable lies of the uterus, and where would we put a pathology or talk about a pathology being placed.
Okay.
The posterior cul-de-sac, anterior cul-de-sac, space of rhesus, like the potential spaces for fluid.
My question is perimetrium just proper name for uterus